Welcome to Season 3 of Under the Sisterhood, Women Making the World Healthier. Our conversations will focus on the themes of women's health and wellness with a new episode every Friday until the end of the year. We will discuss topics ranging from sexual health to mental health while learning from the accomplished practitioners who make women's healthcare possible. This is a podcast to celebrate women and all they do in our role. I'm Elizabeth Elfenbein. Let's get under the hood. Today, we're getting under the hood with Dr. Kattayoun Kordy, a mother, daughter, sister, friend, adventurer, mentor, leader, scientist, big pharma executive, and physician passionate about advocating for women and children's health, and endlessly in pursuit of curiosity. Kattayoun is the head of rare disease and maternal-fetal clinical development at Johnson & Johnson. Triple board certified in general pediatrics, pediatric gastroenterology and hepatology, and clinical pharmacology, her journey in medicine started off traveling the world providing HIV clinical care in developing countries. Her love of the transformative impact of science and medicine led her to pursue an academic career in pediatric liver transplantation and gastroenterology in prominent pediatric transplant centers in the country. She ran her own translational research lab studying the intersection of HIV in the gut and the pharmacologic interventions preventing infection. Her appreciation of the power of research led her to pursue a career in the pharmaceutical industry, and the foundation of her career has been informed by her belief that drug development enables her to more effectively work in service to save millions of lives on a global scale. Kattayoun is working to disrupt the drug development paradigm by innovating successful clinical trials among pregnant women to encourage the greater community to pursue research and therapeutics for this historically neglected population, and to ultimately bring equity and life-saving therapies to women and children globally. Welcome, Kattayoun.
Oh, thank you so much for having me, Elizabeth. This is so exciting for me.
Well, I am so excited as well. Season 3 is Women Making the World Healthier, and you have been on an incredible journey doing work to make women and the world healthier. So it's just amazing to have you here today. So if it's okay, can we get going?
Most definitely. Let's get to it.
Awesome. So I'm asking each woman this question, but it's really interesting to go on the journey and understand the answers. What was that moment in time in life? What was your inflection point that got you into healthcare?
That is a loaded question. Now, I will say that my path has not been straightforward. And in fact, when I look back at it, it's very much like that famous quote from Steve Jobs. You can't connect the dots looking forward. You can only connect them looking backwards. So you have to trust the dots will somehow connect in your future. So with that, I mean, my story really begins as a first generation immigrant. I was born in Iran, raised in the Philippines. My first love, and to this day remains my secret love, is space. I actually wanted to be an astronaut when I was a kid. And it all started when I found an old college textbook in the laundromat at my apartment complex. And even though I think I was only 8 or 9 at the time, I was simply fascinated. Black holes and dwarf stars and the Big Bang. And it was really captivating. And until I found out that you probably had to join the military at that time to become an astronaut. And then that led me into my childhood existential crisis of what do I do now? And interestingly enough, my mom's side of the family, a lot of them were nurses in healthcare. And I thought, okay, well, why not medicine? And that led into some deep dives into the field, even at a young age. So I started volunteering, for example, in high school at a pediatric HIV palliative care in my community, and really got into pediatrics at that point, and specifically in HIV care at that point. And that led me to a journey into medical school, and then subsequently pediatrics down the line. That was probably the pivot point of my career, like many pivot points rather than just one.
So when you came across that, were you in the Philippines? At what point did you come to the US? And is that when you began your schooling experience?
I was probably in first grade when I moved from the Philippines to the United States. So the journey was, my sister and I were born in Iran because of the political turmoil. My parents took us to my mother's homeland in the Philippines, and I was raised on the island and grew up there in my childhood. And we had a lot of family in San Diego. So we actually, my parents were very much wanting for my sister and I to grow up in a different environment that supported education for women and had the opportunities that they didn't have. So we moved to the United States, and I actually found that book, in one of our first apartments that we lived in Texas. So we moved around a lot in our journey through this country, and we've been very fortunate to have many opportunities, my sister and I, as we've become settled into this wonderful community. And we obviously consider ourselves Americans, and so we're very proud to be here and contribute to our society.
So you go off to college. Talk about your medical school experience and coming out of that.
So when I was in medical school, I was just so excited. There was so many things that I could learn, so many new areas that I never even thought about. And during medical school, we did rotations in various practices. And one of probably my most favorite rotation was in transplant surgery. And it was just this fascination with how transplant surgery, in addition to the immunology that you needed to understand, was extremely transformative. It was life-saving. You had patients, for example, that were literally on death's door. And you have this amazing, incredible gift from a donor who had just lost their life. And you were able to then reconcile the two and see such a change, a remarkable and quick change in the recipient, where there's now are finally awake, talking, and on that road to recovery. And it was just transformative, not only for the patient, but also for their families. And it was that introduction into transplant medicine that led me down the path of, hey, I love pediatrics. So I went into general pediatric residency, and I continued to explore the transplant space, specifically the liver transplant space. And that led me to a fellowship in UCLA for pediatric gastroenterology and hepatology. And UCLA is one of the leading transplant centers for liver and intestine in children. And that was an education in itself, because that actually allowed me to do some dive into research for the first time in my career. And I had obtained a clinical pharmacology grant from the NIH and started to do work that merged not only my interest in HIV, but also the gut and immunology at the same time. So some of my early research was actually in that merger of all of these areas that I was interested in, and a lot of creativity actually, which was really cool to be able to integrate that science and creativity together and to create some new data and some new knowledge that the world has not seen before. So that led me to this incredible fascination into research. And interestingly, when I got this clinical pharmacology grant, I was able to sit for that board certification. And with that, there were some folks in industry at Novartis that were interested in my skill set and brought me in as a pediatric drug development expert. And that led to a different career that was something incredible beyond what I could ever imagine, that had tremendous amount of impact. And that has now led into even a further extension into an exploration in a new disease area for me in maternal-fetal medicine, and being able to then develop drugs for women with pregnancy-related indications at J&J. So it's been quite an incredible journey following these dots.
I know that you talked about leaving medical school and going straight into developing countries to support the HIV clinical work. Can you talk about that?
Now, that was possibly why I went into medicine, actually, now that I think about it, was to provide access to care in developing countries that didn't have access to care. Now, having grown up in the Philippines, where medicine is not so accessible, it was really an early impact, I think, in my life that I wanted to contribute to those populations that didn't have such opportunities. And so following that interest in HIV that I started developing when I was in high school and medical school, I continued to explore HIV as well. And I started off with actually a rotation in Malawi through a Baylor initiative, Baylor College of Medicine initiative that provided pediatric HIV care in Malawi. And so I was able to firsthand go there during medical school and really see firsthand how antiretrovirals and management was provided in developing countries, and learned a lot, not only from the HIV perspective, but also from malnutrition perspective and access to care and what tools are actually available to citizens in other parts of the world that didn't have the proper infrastructure like we see here in Western countries. And that continued on this, I guess, fire that I wanted to pursue. So after my pediatrics residency, I actually practiced abroad for a year. And my first job after I became a freshly minted doctor was to actually go to an NGO that was in South Africa, in the middle of nowhere. The purpose of that role was to be able to provide pediatric HIV care in this, originally was a palliative care clinic. And it was really interesting because when you are a physician in a township of 25,000 people, you end up actually taking care of 25,000 people. And so my work extended beyond just pediatric HIV. It also dove into managing the huge tuberculosis population that was there, as well as just general health for women and men in the community, as well as the children. And that was possibly one of the most joyous most challenging times I've ever had in my career, because you really had no resources. I just had a cabinet full of medicines. I had my stethoscope, and I was running my own labs. I was running my own x-rays. I was reading my own films. And I really relied on my community to help support me in order to support the broader community. So it was a fascinating lesson in real medicine to me. And that opened my eyes to even doing more work abroad in Thailand and in Ecuador and the Andes Mountains. And it was just possibly the most, and remains my cherished memories of my initial, indoctrination into medicine.
What did it feel like? I mean, I would imagine, were you supported by other physicians? Were you of solo? Like, what did it feel like to be in that circumstance when coming out of, a country that is so powerful from a healthcare perspective, and coming out of the education and the experiences you had with all the resources you had? What did that feel like emotionally, and the whole experience?
Emotionally, I would say it was intense, as you can imagine. Thankfully, there was a local doctor who was part of the community but had his own private practice. So that was his main business, was his private practice. But he would be, if you will, a physician that also part-time worked at the clinic. I would often, call him for advice or questions about, the particular patient history, as he was in this community for a long time. And he was really a great support as well. And I also had an infectious disease doctor in UT Southwestern, where this program was in partnership with, that would consult with me over Wi-Fi that was extremely spotty. So it was hit and miss sometimes on the connectivity there, but always a great support. So there, more importantly, though, I'd say the support really came from that strong network of the local community members who work for the clinic, who were these folks that would then go out into the community health care workers that really would deliver the medicines to the patients, that would count the pills to ensure that they were taken, that would then alert me to any problems in either adherence or further complications in these patients, and then they would bring the patients to me, or they would communicate with me what is needed. They were also the people that helped negotiate certain discussions with family members, or even the local sangoma, or the witch doctor, that really was the main pillar in the community for healthcare in that particular community. So it was actually a lot of learning from the community, from the people who worked and lived in the community, from these wonderful people who really cared for this population. And it was a world of its own. It felt extremely intense, and there were many highs, many lows. And mind you, I think I mentioned to you earlier, this was originally palliative care, because at least when it first was in inception, a lot of people with HIV just died because they didn't have the right antiretrovirals, or didn't have access to antiretrovirals. And now we're seeing these patients actually have access to basic antiretrovirals. And we're seeing some improvement in the length of life and quality of life, but still people continue to die in this space.
So after you experienced and you went and you worked within communities and really in public health, and you came back to the US, what was your next experience like? Where did you start practicing medicine, and what was that? What did you do?
Right. And so actually, that's a really great question, because I had planned this one year to practice pediatrics, and I planned to do this work in developing countries. But I had also had this passion for transplant medicine. How do you merge the two, really? But I went ahead and proceeded with my fellowship application for pediatric gastroenterology and hepatology. And so at the end of that year, I started the program, which is a 3-year fellowship program at UCLA. And as part of that fellowship, it was actually mandatory that you do research. And for me, I was fortunate to get that grant that I was telling you about. That was clinical pharmacology. And my first foray into thinking about what kind of research I wanted to do, because I felt, at least at that time, I was not meant to be a researcher. I was no interest in research per se. I found a mentor who was doing HIV work, who was a gastroenterologist. And there are medicines that you can administer that will help decrease the transmission. And so I wanted to do that research for the adolescent population. And so my first research project was, how do you prevent transmission of HIV into the intestinal mucosa or the anal mucosa by using an antiretroviral? And that led me into this merger of the HIV mucosal immunology interest with gastroenterology. So it was a beautiful merger, and that led to some great additional work on the microbiome in the gut. And then it went into microbiome in inflammatory bowel disease, and then it led to the microbiome in breast milk, and it just exploded in my interest in research. And so that had led me into this possibility that research actually has a different place in medicine, that it has the ability to impact not only patients on an individual level, but on a grand scale. And this fascination then ultimately led me into the industry path.
You happened upon that, and the research sort of got very exciting to you, and then you went into pharmaceutical industry to make that more, shall I say, impactful. What has that experience been like?
Much like I didn't anticipate myself as being so into research, I definitely did not ever anticipate being in the pharmaceutical industry. The reason I went into medicine was more of what my original story was, impacting lives in developing countries, and then it grew from there. And what was fascinating about Novartis was the experience that I had with Novartis was that it allowed me to have a glimpse into the types of science, the types of people, the types of resources that are available in industry. And it is certainly world-class and cutting edge. And the extent of collaboration that occurs amongst these group of people, the extent of passion that drives drug development, really spoke to me. And so when I first transitioned into industry, it was at Novartis, helping with the pediatric drug development aspect. And my role was to help teams across the entire Novartis portfolio to think about pediatric drug development from early to late stages, to create new therapies for pediatric patients that have had great unmet medical need. In some cases, creating first-in-child studies, or in other cases, doing fastest-in-child studies in disease areas across all indications, such as infectious diseases like malaria, for example, and all the way to advanced gene therapies that cure rare diseases in children. And it was this ability to see the impact that these teams have, that the industry has, the resources that they utilize to get drugs to market to these patients, to change and transform lives and change history books. That was what got to me. And it goes back to that initial purpose that you mentioned, Elizabeth. When I think about articulating what I'm here on Earth to do, it is to really impact lives on a global scale, to reach millions of people. And this aligns with that beautifully. And so after my time at Novartis, I was fortunate enough to build up a skill set in rare diseases and innovative trial designs. And that was really alluring, I think, to the point where Johnson & Johnson is developing in this very rare, very difficult maternal-fetal immunology space. And I was recruited into this position to be able to create innovative approaches in delivering these transformative medications to women who have really serious diseases during pregnancy that could impact the outcome of their fetus or newborn down the line.
So that must be so inspiring because it's a kind of a blank canvas, right? So talk a little bit about that.
It does create, you do need to create something new, something that perhaps pushes the boundaries of what has typically been done. And for that, you really need courage. Courage and the ability to share ideas in a diverse group of people to create something new. Science has always been a team sport, and leveraging everybody's diverse skill set in areas that typically would not be considered, whether in study design or drug development, is what you really need to innovate in the space. And having that culture where you can speak up, that you can create new ideas, that you can riff off of each other and innovate, and not only within our little sector, within industry, or within our little group, also innovate outside the space, right? Being able to push the regulatory landscape into something new. Also then create a new way of approaching markets or patients or investigators or physicians that typically don't have therapies available to them, that typically don't have experience in clinical trials. Shaping this new market and engagement externally, that's what we're doing here at J&J, and that's what you do in rare diseases, that's what you do in pediatric diseases, is to create a new ecosystem. And creating something new, I cannot emphasize this enough, requires this creativity and this braveness, this boldness to try and fail is part of the recipe, I think. And failure, someone once told me, actually stands for first attempt in learning. And that's what I embrace, is these challenges and learning from these failures to create something more exciting, something new that can actually transform care.
In a previous conversation, we had a conversation around creating the seat at the table and the table itself. So do you want to talk a little bit about your experience? Because I know that in this new landscape that you're creating, it's important to have a seat at the table. And if not, what does that look like?
One thing that I learned in my industry experience is that there are many great unmet needs in women and children's health. And to be able to develop drugs in this space for them. It's very, very important to have advocates who do have seats at the table, who will be the voice for these patients that typically aren't your typical research or market opportunities, right? It's important to have their voice in your mind when you're creating strategy, when you're creating advocacy for what diseases should we go into. And I think that's one unfortunate thing about where science has been and research and development has been recently, is that there's been a long gap in science in women and child's health. And there's been a long history of fear around pursuing research in these important populations, which has really resulted ultimately in a significant gap in treatment innovations. Now, just to give you an example, the women who have autoimmune diseases, someone in your life that have an autoantibody driven disease. And interestingly, 80% of patients with autoantibody driven diseases impact females. And up to half of these women are of childbearing potential, but there's only few safe, effective therapies for use during pregnancy and lactation. And we need to change that.
Well, I know that we talked a lot about, this really gets into kind of health equity. What are your thoughts on that as it relates to both all the work you're doing and in general, Kattayoun?
It's a really great question. Now, I'll start off with saying that there is, just stepping back, there is a maternal mortality crisis across all demographic groups in the United States. The US maternal mortality rate is nearly 10 times greater in comparison with other wealthy nations. Surprisingly, 60% of these deaths are preventable according to the CDC. What's possibly even more shocking, I think, is that the Black, Indigenous, and people of color, or the BIPOC community, are disproportionately affected. And these groups are 2 to 3 times more likely to die from pregnancy-related causes than white women. Now, there are many complex factors that contribute to these health disparities among the BIPOC community in particular, ranging from underlying disease pathophysiology to lack of access to quality medical care to racial inequities. And certainly, the science shows us that immune-mediated diseases do occur more frequently and tend to be more severe in these BIPOC communities. They often experience greater disease severity and faster disease progression than white Americans. However, it's this lack of access to quality healthcare that really compounds these issues. And based on recent US Census data, most BIPOC groups are more likely than white people to live under the poverty line, which actually limits their ability to pay for and access medical care. And additionally, there's just been recent research actually that demonstrated a link to racism and negative birth outcomes. So just to tie this out, just more broadly speaking, like medical research continues to have underrepresentation of BIPOC groups, who only make up less than 10% of participants. So this particular example just highlights, that population that has a tremendous amount of great unmet medical need. Going back to what I was saying, traditionally there's been a long history of fear in pursuing research and development for these populations. And we're seeing that the outcomes of that now with these high mortality rates. We need to develop therapies and treatment innovations for these populations.
It is also so complex when we think about health equity. So women are 50% of the population, yet it wasn't until 1993 till the clinical trials that became part of clinical trials, and so many different reasons, what have you. What would you like if you were to create the perfect world? What would you start with first, and how would you even begin trying to solve an unmet need here?
Absolutely. It goes back to actually like that seat at the table that we were talking about. Like, we need women and men to advocate for women and children's health. We need people who have the influence, the people who have the ability to impact portfolio strategy, the ability to fund these extremely valuable research into these unmet needs, to speak up and advocate for and choose to do development and research in this very difficult space. Now, this may not be a surprise to you, but it's important to keep emphasizing that investing in women's health is actually extremely valuable. There was a recent research that was done by McKinsey that found that women are expected to spend 25% more time in poor health than men. And it's namely due to the lower effectiveness of treatments for women, worse care delivery paradigms, and just a lack of data. Now, if we as a society address this 25% health gap, it will not only improve the health and lives of millions of women, but it could also boost the global economy by at least $1 trillion annually by 2040. And on top of that, when you look at how healthcare spending decisions are made in the United States, women actually make 80% of those decisions. But in a very imbalanced way, only 4% of all our biopharma research and development spending goes towards these female-specific conditions. So ultimately, investing in women's health is not just about the positive economic outcomes. It's really foremost, as you mentioned, an issue of health equity and inclusivity. And we can have the potential to improve the quality of life for half of the world's population and create these positive ripples in society.
And this has been a really interesting and fascinating conversation. Your story is extraordinary. Before we close out, how do you imagine, what do you see your future looking like in the healthcare space?
I've had this North Star as I've gone through my journey in medicine and in industry. And this particular North Star is to create that table and create this setting where I am the CEO of my own female-led company, and we will tackle the world's challenges for women and child's health, to be the ones actually developing drugs for these patients, to not have to beg for money, beg for funding, beg for research in this area. We will create that table and develop in this space and do it so successfully that we will change the world and their perception of developing in this space. So that's the ultimate dream one day. And in the meantime, today, and I continue to speak up for these patients, and also encourage my colleagues to speak up for these patients. And hopefully together we can change the world and change perceptions in our journey through our careers.
This conversation has been wonderful. I ask every woman, this is a platform for you to give a message to women around the world, of course, everyone around the world, but, women, because we're here to really inspire the next woman and lift women around the world from all ages, all cultures, all backgrounds. What do you want to say to them, Kattayoun?
Well, I'd say be bold, be fierce, be curious. I'd say don't listen to the noise, and find something that really sparks you, something that drives you, and follow those dots, because it's ultimately you who will be the one driving your life and your career and your impact on the world. It's very important to never apologize for what you believe in. So fiercely follow your passion. And I go back again to that Steve Jobs quote, because I do want to emphasize, for me, it meant a lot. And I think for a lot of the listeners out there, it may mean something to them too. You can't connect the dots looking forward. You can only connect them looking backwards. So you have to trust that the dots will somehow connect in your future. And you have to trust in something, your gut, destiny, life, karma, whatever. And I'd say just follow those dots.
With all my interviews of over 100 women, one of the common themes has been trust your gut in a lot of the conversations. So I think that's a great message, being bold. And, thank you so much. You are incredible. You are a remarkable woman and physician. And I'm really grateful for this time to get to know you and get under the hood with you, Kattayoun.
Thank you so much. And thank you for having this platform for women like myself. I'm really honored and so deeply humbled to join the sisterhood. And I know there are many of us out there. So thank you for highlighting this particular little tiny story of mine.
Oh, your story is not tiny. It's definitely not tiny. Thanks for listening to Under the Sisterhood. If you haven't already, please give us a quick rating and review on Apple or Spotify. And make sure to follow us on Instagram, Facebook, YouTube, and LinkedIn so you can hear from more amazing women. This podcast is created and hosted by Under the Sisterhood LLC and Elizabeth Elfenbein, produced by Elizabeth Elfenbein and Matt Butler, and edited by Matt Butler. The music is by Ayla Schaefer. Her song, Rose.